Welcome back to the Game-Changing Women of Healthcare. I'm your host, Meg Escobosa. A quick note before we get into today's episode. We are currently looking for sponsors for the podcast. If supporting and encouraging female leadership in healthcare is important to you or your organization, help us do that by becoming a sponsor of the Game-Changing Women of Healthcare. Reach our engaged audience with a mention by me in future episodes, or we'll produce a short audio spot for your organization. At the Krinsky Company, we believe in female and diverse leadership in healthcare. If that's important to you too, become a sponsor of the podcast and proudly share your values with the world. Reach out to us at podcast@thekrinskyco.com. And thank you. Welcome to the Game-Changing Women of Healthcare, featuring exceptional women making an impact in healthcare today. Together, we dig into the many healthcare issues we face today and how these innovative leaders are working to solve them. And we celebrate our guests' accomplishments, setbacks, and the lessons they've learned throughout their careers. I'm Meg Escobosa. Join me in conversation with some of the many brilliant and courageous women on the front lines of the future of health. Today on the show, we're joined by Dr. Jennifer Schneider. Dr. Schneider is the co-founder and chief executive officer of Homeward, a company focused on re-architecting the delivery of health and care in partnership with communities everywhere, starting in rural America. Having grown up in a small town and being diagnosed with type 1 diabetes at a young age, she experienced firsthand the challenges of accessing convenient care that millions of families across rural America deal with every day. This fueled her passion to found Homeward and create novel, value-based care models that are purpose-built to address the needs of rural Americans. Previously, Dr. Schneider served as Chief Medical Officer and President of Livongo. While there, she led the company through the largest consumer digital health initial public offering in history and the industry's largest merger ever between Livongo and Teladoc Health. She also served as Chief Medical Officer of Castlight Health. She completed her bachelor's degree in biology at the College of the Holy Cross. She went on to get her MD at the Johns Hopkins University School of Medicine and her master's degree in health services research at Stanford University. Jenny, welcome to the show. We're so happy to have you here.
Thank you so much. Excited to get to be here.
So Jenny, Homeward Health, you're tackling rural healthcare. Tell us about this problem. What is the biggest challenge with getting care to rural areas today?
Yeah, sure. Thanks, Meg, for the question. So just to take a step back, when we did the transaction of Livongo, I had a chance to take a moment and reflect and think about what it was that I wanted to concentrate and spend my time on next. And as part of that journey, I spent some time with my co-founder, Amar Kendale, and we decided that whatever it was we wanted to do, it had to be really big and it had to move the arc of healthcare in the right direction. And so we spent time thinking through different theses and different ideas. And where we landed was we found something that was really big and broken that we thought we could be helpful in uniquely fixing. And that was healthcare delivery in rural healthcare markets. So if you take a look at outcomes for people who live in a zip code where the last 3 digits designate you as rural. And for those of you who don't know, there's a RUC listing and there's 9 different zip coding classifications. The bottom 3 are rural. If you live in a county that's designated as rural, your healthcare outcomes are far worse, to the tune of 23% higher mortality. We also know that in these rural markets, hospital closures, rural health clinic closures are increasing at an exceeding rate. There's half the number of primary care doctors and about an eighth or a tenth the number of specialty care doctors. And 10% of all rural counties have zero healthcare services whatsoever. So Amar and I said, okay, do we have experience here that may be useful to help build? And the 2 key core tenets that we came up with were, number 1, you had to build healthcare services on a technology stack such that you could scale. Mm-hmm. In an area where there were not services, you couldn't artificially imagine you could bring more services into the market. So we had a lot of experience doing that at our various companies in the past. And the second was we really had to align economic incentive for healthcare delivery. We really wanted to give people the right and the opportunity to get paid for doing the right thing to keep people healthy in the system.
Right.
Another buzzword for that is value-based care, but owning the responsibility, financial responsibilities, and therefore acting appropriately on what types of care could be delivered. So those were the two key core tenets. And so we launched Homeward about a year and a half ago.
That's super exciting. And value-based care itself, just defining that as you're paying for prevention versus treatment, or, right? You're really trying to keep people healthy.
That's right. And you do end up paying for both, let's be clear, but there is definitely a larger emphasis on what can I invest in to keep people healthier? And sometimes that's healthcare, flu shots, COVID shots, blood pressure screening. Sometimes it's food adequacy, or ensuring that there's safe transportation to actually get to a specialist so that appointment actually does happen and isn't avoided. And then you live with the long-term consequence, which are often worse for health and worse for the economic system within healthcare.
And in rural areas, there are so many challenges. Technology, do you find that relying on technology in this area is a challenge for patients?
It's an interesting question. I think that technology in general has a real opportunity to advance us in healthcare delivery, particularly as it can take out a lot of the inefficiencies. So there's a lot of technology assets that can be used that nobody even feels that they're being used. It's just that the process is better, it's faster, it's cleaner, it's more accurate. So there's no hesitation on a member usage for those applications of technology. In addition, I do think there are things that we ask or encourage our members to do vis-a-vis technology, such as remote patient monitoring, such as telehealth. Rural is different than urban in that there's a higher level of trust, meaning you have to overcome a higher barrier to be able to deliver services. So it's this combination that we've learned around being in person and delivering technology services. It's not simply mailing technology to somebody's house and asking them to use it. It's spending the time to get to know the person to set it up so that they trust the system, and then they'll start to use it and continue using it.
Right. Why do I have this tech?
That's right.
What's the benefit?
That's
How do I get better because of it? So your website is fabulous. You have some great images, and I see a very cool vehicle. Can you describe, how do you actually deliver care? What is Homeward Health? And is it Homeward Health Care?
It's Homeward Health.
Homeward Health. Okay.
Yeah. And so Homeward comes in the way that the model works. I'll talk about our business model and then our care delivery model.
Great.
So the business model is we partner with insurance companies, so payers, and we partner with them to take on full responsibility of the lives that they have in a rural county. So, for example, a member may have Medicare Advantage members, dual eligible, Medicaid, Medicare, Medicaid. And we come in and say, great, we're going to be financially responsible for those people and ensure that they have improved clinical outcomes. So the first thing we do is we leverage our technology and our data to help inform those existing primary care doctors how they can perform better. So we partner with existing primary care doctors, not in a competition, but as an added benefit, an added bonus to their care delivery practice. And then when we identify gaps in care for services that have not been done, cannot be done, may not exist in that certain county, we come in and fill those service gaps with our own clinical team. The combination of the two is really important because we know that there are great doctors in rural America. It's not a commentary on the doctors, but they're often overworked and they don't have the time to actually do all the things that need to get done. But in some counties, there's simply not enough care clinicians to actually provide the care that's needed.
Right.
So it's that combination of leveraging our services for the primary care doctors and existing health systems within that county, allowing them to practice better, deliver better outcomes, participate in a value-based care arrangement with the payer, and then filling those gaps and holes where they exist. You mentioned it's not in competition with the physicians. What's the response to providers and from providers to your services? Out the gate, we knew that I come from a rural America, so I know this, right? So if there's not enough healthcare services operating at high quality in the market, coming in a competitive force doesn't help anybody, does not help us accomplish our mission. So we took actually a very different approach, and we looked across the ecosystem and said, who is there that we can partner with? One, make them better, and two, make us better on behalf of the community of the members that we're servicing. And so we're not in a competitive moat or mode at all. In fact, our services that we supply to the existing health systems and providers are very much welcomed because there are things that they don't have, data that they can't receive, extra hours, extra hands that they don't have to be able to deliver the care that they want to deliver for the population. Again, this is a win because what we're doing is making communities healthier, allowing providers and health systems to operate more efficiently, and aligning those economic payment terms such that the payers are giving the rates to the doctors when they're doing the right thing for the population. And we help providers make that transition into value-based care by backstopping the financial risk in this process.
Sounds like a real benefit. Data piece. So today, data lives in many different places. Do you rely on the payers for understanding the...
I would say yes, and is how I would answer that. So we integrate for sure from electronic health records where doctors are inputting their information. We absolutely receive claims from the payer, the insurance arm, to understand what they're catching and collecting overall. We have our own streams of data that include things like real-time remote patient monitoring. So this is very much can we collect the data and then can we identify the population that has the highest need and go intervene in that population? So the answer is yes. We ingest, we normalize, and we leverage that data to help guide decisions for existing health systems and providers in the county and for us as we supplement that.
And when did you go live with your services?
We went live late last summer in Michigan, about a year, and then live in Minnesota earlier this spring.
Congratulations.
Thank you.
How has it been going, and how much more complex is it now that it's up and running versus what you envisioned? I mean, it's always, when you get into something big, knowing what it really is when you're starting, you might not start. I'm curious if you've had any of that experience.
Well, having gone down this journey 2 other times, I think the simplest idea in healthcare becomes highly complex because it's a regulated industry. And so under every corner and turn, there's lots of surprises, even as you're starting out. Even as you're finishing, there's still lots more surprises. So the answer is we are so proud because the people that we've been able to serve and service love what we're bringing to them. It's very clear that we're hitting a need within the market and really delighting the end members that we're providing care, to whom we're providing care. So that is our North Star. That is why we're on this journey. And sure, every state, every county has its own unique complexities, but we've figured out a number of patterns that have allowed us to be able to actually start to scale this more nationwide.
Okay, that's so cool. So let's back up a little bit more I feel like, so we've talked a little bit about the back end. Can you describe what the patient experience is so that we can really, get a feel for that?
So about 70% of patients today identify that they have a primary care doctor. That means they have somebody that they see. So imagine, Meg, you go in to see your primary care doctor, and we've been working in the background, and we notice that your blood pressure is up a little bit, like intermittently, and your primary care doctor kind of notes it on the chart, but isn't super concerned. We may say, hey, look, with your primary care doctor, we're going to deliver a remote patient monitoring tool to you to follow and track your blood pressure such that we can see what's happening when you're outside the doctor's office. You only go to the doctor's office 2 times a year. You're in there for 10 or 15 minutes each time. So we can start to understand and track so that saves you a trip to the doctor's office. It saves the doctor themselves a whole slot that needs to be filled with somebody who's maybe more critically ill. Right. And so what is like more attention, more care, and a decision-making plan that helps augment what you need in that time.
And it's at no extra cost to the patient?
No extra cost to you, right? Because
Yeah.
what we're doing is we're actually sitting on top of that and making sure that you're receiving the services that you need, and that's a service that you would need. Yes, that's right.
I'm curious if bringing up even just the food desert, so to speak, in some areas, having good, healthy, nutritious food, is that even recommending things like that? Access to, how would you address, say, that challenge? Let's say somebody just needs a better diet. That's the observation.
Yeah, and that's an observation in lots of people who live both in health deserts and in rural markets. So that's not an uncommon observation. But there's also a lot of solutions typically. There are a lot of other links within the community that somebody may not know about. There may be food services, soup kitchens, or maybe fresh fruit deliveries that they just haven't tapped into. So the first thing we do is actually understand deeply within that community what's available, what's included in the insurance plan that these people who are in Medicare Advantage have actually enrolled in, and help them navigate those benefits. Like, that's a big step, and you can get pretty far in that. I mean, we forget as care providers, the system is very complex for people trying to navigate it. And oftentimes someone needs an advocate and a navigator to help them figure out and connect the dots as to what those benefits are and just make them real and make them happen.
It's amazing. Yeah. Let's talk about this leadership role you're playing, like launching businesses, leading them to M&A outcomes, your mergers with your Livongo experience. Can you tell us about what it was like to be a part of Livongo, help merge it with Teladoc, and what that experience was like? And
yeah. So I think that the key to any great business, not a good business, but a great business, is to keep your eye on the mission. And I say that in Livongo, we were incredibly mission focused. And there, our mission was to empower people with chronic conditions to live better lives. That's it. Like, it wasn't to take the company public, which we did. It wasn't to sell the company, which we did. It wasn't to raise more money along the way, which we did. It was every day we talk about how can we empower, not help, how can we empower people with chronic conditions to live better lives? The reason I say that is that when you stay focused on that, you take advantage of these opportunities that help you get to scale differently. So many times young entrepreneurs will say, well, my exit plan is to be acquired, or my exit plan is to take an IPO. And like, none of those are exit plans. Those are, in my mind, those are just, there may be offloading for financial outcomes. You may be able to take some money off the table, but the real exit doesn't exist if you're accomplishing your goal until you get to your goal, right?
Yeah.
And so, and if you
it's
do
a great
that,
way to frame it.
yeah, and if you do that, you will have many more opportunities to scale the business. So I think an initial public offering, an IPO, is nothing more than a very big, massive branding event. It's a capital raise, and it's a signal to larger markets that you have the infrastructure to actually continue to scale to accomplish your goal. So it's like the bar mitzvah, right? Or it's the quinceañera of growing up as a business, but it's not the end destination. You don't think your life is done once you've worn your fancy dress and when celebrated with your family. Like, that's just a rite of passage. Similarly, when we did the merger with Teladoc, the thesis was we needed to link closer to providers to get prescribing power and get closer to be able to provide that full suite of services. Remember, we had a platform for chronic conditions, diabetes, hypertension, behavioral health, obesity. We had coaches, but we didn't have providers and prescribing power. I still, to this day, believe that the thesis of combining those two entities is incredibly powerful and was the right next step for the evolution for us to continue on what our mission was, which was empowering people with chronic conditions to live better lives.
I mean, your framing was just, it's really fresh, and I appreciate just thinking about, staying mission focused is obviously a key way to run a great business, but your point about just not thinking about the exit, that isn't the priority, to stay on your goal. It's very fresh, and I appreciate that a lot. What was it? What do you feel like your other insights and learnings are from that experience, and how is it informing what you're doing now?
Yeah, I feel like I'm so fortunate because I've had incredible learning experiences, often with other additional positive benefits. But I've done a bunch of really stupid things over the course of working and learned mostly from my mistakes. And the thing that I walk away most from Livongo was that if you can build a team, leadership is about building teams and inspiring people to do their best work. And if you can do that, and you can do that in a way where people feel rewarded and they feel heard and they assume positive intent, you can accomplish anything. And that as a leader, and this goes for teachers, it goes for coaches, it goes for parents, if you can state the slightly beyond possible, slightly beyond what everybody knows you can do, that's how you have the breakthrough. That's how you get to that next level. And so the idea around healthcare company creation is not to create something that's already in existence to add more noise into the ecosystem. It's to break a barrier. It's the Roger Bannister 3-minute mile, right? It's like you're breaking a barrier. And so your job is to motivate, inspire people to work toward doing that. Celebrate the wins, celebrate the failures, and allow an environment where people feel they can leave the fear behind them and actually try to go for it. And I learned that lesson in spades at Livongo, and the culture that comes with that, and the enjoyment of work, and the amount of laughs that we had together as a team as we were creating something was a really incredible journey and experience for me.
That's a great way to frame it. Again, just wow. I absolutely agree with you and have experienced that myself. When people push you to see beyond what you think you can do, it's powerful. Can you talk about one of those failures? I want to hear a story about something that
sure.
It doesn't have to come from Livongo, could be anywhere, but just be interesting to hear, like, you know what? This is what happened. This is what we learned from it.
Well, I can talk about a very clear Livongo one. So it was going on between 2016 to 2017, and we had decided as a leadership team that we wanted to become a platform, which a lot of people use that word now, but we wanted to become more than a point solution. So we launched in diabetes, and we decided to launch in hypertension. And I made a decision to launch in hypertension with people with diabetes. So we weren't going to build 2-point solutions on a platform. We were going to build 2-point solutions that intertwined to address like a complex. So it's a much more complicated build. And the build seemed to go great. The team was great. I brought in an incredible, very smart cardiologist, Bimal Shah, became our chief medical officer. He was great. And then I got to launch the go-to-market strategy for that with our sales team. And I did that over the holiday break. We had our go-to-market kickoff in January. I think it was in Texas. And I stood up and launched it, and it felt like I've not had like such a negative response, because the sales team's response was, why would I try to complicate? You've just complicated my job. I'm selling diabetes and it's selling great. Like, well, that's great for you. It's just not great for the market, like for the business. Like the business has to evolve. People's experience has to evolve. But what I learned in that process is I had done all the work in the building. I had not done enough socializing work to get the buy-in at the go-to-market sales motion. So it was a unified flop in terms of announcing it to the sales team. It was still the strategy we stuck to. It ended up becoming a winning strategy, but took a lot more revs to go back with my head between my head bowed and tried to explain the why. And so for me, there was a lot of learning there in what it takes to socialize and steer the course of a business. Even a business that's moving really quickly and iterating very quickly, there's still a lot of time to get people's mind shift to change.
Yeah, very good point. Did you have much experience engaging the market itself as well? Did the market respond it sounds like it was successful. Was there a voice of market element to your work as well?
There was, for sure. We did a lot of we had a lot of client advocacy meetings. So we had a client advisory board. And so they helped give us a lot of ideas. Oftentimes they would tell us that we'd bring in an idea and it would be completely shot down, which is humbling and very rewarding. And so this idea around being open and not wedded to your own ideas is really critical as you build businesses and build an experience. And so I say this all the time, the number one failure is no, I know I'm right. I'm going to just keep going. You actually have to listen to the people that are trying to buy what you're trying to sell. And if you can't do that, no matter how great what you're building is, if you can't sell it, it's not a great business. Right?
Yeah, it's going nowhere.
It's going nowhere, right? And I recently had somebody come and say that they had gotten feedback that they themselves appeared very young in presentation, and that someone's like, well, that's okay, you're just young and smart. I was like, actually, if that's the consistent feedback, bring somebody else who looks older. Like, don't try to just like fix the problem. Like, it's not on you, it's not a problem with you, but like if that's the business problem, like fix the business problem, right? If that's the feedback you're getting, fix it rather than fight it. Those of us who try to fight the feedback we're getting from the clients that we're servicing don't do very well in terms of building businesses.
I hate to hear that. They're too young looking.
Sure. So do I.
And too old looking.
Right. For sure. And I get that. Right. And that's not a value that is consistent with your value or my value. But the conversation is different, which is like, fix it as a business problem. You can hold your values, but you have to fix the business problem as to like what's happening in that process and that cycle.
Yeah. Okay, I want to hear about Homeward Grown.
Yeah, so I'm really delighted with the help of the Homeward team. We announced Homegrown, which is an initiative for me to get to formalize the sponsorship that I get to do across female founders. And what that means is there's an application process. We allow and expect and are really honored to have people apply to come in, and I spend time on a quarterly basis with female founders talking about whatever it is that they need. It may be fundraising, it may be leadership team, it may be cross between personal and work life, whatever needs they have. I just get to be a sounding board or a resource. And for me, selfishly, it means I get to have connection with these really incredible women who are coming up with great ideas and hopefully carve out a little bit of an easier path, having bumped into some things myself. But it's a mutual learning. It's a real opportunity, and something I am delighted to get to do and feel honored to be able to do.
I just admire it so much. I think that's part of where we're coming from too, with having this platform, the Game Changing Women of Healthcare podcast, to engage with women, their experience in leadership, their learnings, their insights. And this mentorship piece is such a critical one. I mean, the number of times I've even heard and felt personally the concept of imposter syndrome, believing, and just the stats about women not going for things when they see a job opportunity, that just they don't have 100% of the skills that are required of roles and opportunities. They just step back and keep back until they think they are fully 100% experienced enough. I don't know if you've noticed that yourself in your observations connecting with women pursuing leadership.
I think it's a common trait where women want to be trained and confident that they have what people are looking for. I think once you've been in a leadership role, you realize that half the time you're making it up as you go along anyway. And so the training was nice, but maybe all that relevant. I have 2 girls and a boy, and all of my children, I think we live in a very empowerment household, and like we don't say you can't, we say I'm not allowed to. Like right now, you're not allowed to jump off the roof and try to fly. Not that you can't, you're just not allowed to do that right now. But I did. My middle daughter, when she was in the 2nd grade, I got to go to her classroom, and it was like a parent teacher. They showed you the work they'd been going on, and she immediately walked up to like a 6th grade work thing and sat down. It was like long division. She was in the 2nd grade. So I was like, I'm pretty sure she doesn't know how to do this. And the teacher comes over and she's like, she doesn't really know how to do this. I was like, I know, but she believes that she knows how to do this, and she has the confidence. And so I sat there and watched her again
work it out.
Yeah, well, she didn't really know what she was doing, but I was so proud that she didn't have that. So the reason I say that, I don't think we're born that way. I don't think it's like we're born with that. There's something about society that influences that. Like, why can't we all just act like we can do more things? Because half the time you actually can do it. Half the time you still can't, but half the time you can. And so why not take that chance?
Yeah, it's fabulous. And I know, so if somebody's out here listening and they themselves are a founder, they want to get involved, how do they get involved in Homegrown?
Oh, great question. There's a website on our Homeward Health website, so just come take a peek. There's a application, link for an application. So be delighted to review and get to meet, or just reach out. We've got lots of people. I reach out directly to me or to someone on the Homeward team, but would love to have a chance to meet and hear if I can be of use in any way.
Did you have mental benefit?
I did. And this idea around paying it forward is an incredibly important one. And I had good fortune of having both female and male mentors. So I had Dina Bravata, who was the first chief medical officer at Castlight. She's an incredible mentor and friend. I had Sandy Fenwick when I was at Livongo, who is the CEO of Boston Children's Hospital. I had John Driscoll, who is the president at us at Castlight for a while, who has continued to lean in and pay it forward with mentality. And again, there's a intellectual help, and there's a relationship that you get when you have multiple genders, multiple generations over time.
Yeah.
And I like to say, like, there's no reason why everybody needs to have the same set of scars on their back. Like, get new scars. Like, there's going to be other hard problems that you're going to have to uniquely face, but like leverage those people around you who've done it before and can maybe help shortcut. There's no pride for copying homework in the early stages of the things that can help get you further faster. And so I think it's a humility to ask and a delight for people who've done it before to get to share.
A platform like ours, the podcast,
Yeah.
what do you think we can do to women achieve more leadership for themselves in healthcare?
It's a great question. I think I don't know if you do this, but one of the things that I think a lot about for me in my role is like, what am I grappling with, and am I alone, right? Am I alone in asking in these things? And so as you think about bringing people on for interviews, my hunch is you often have people who've accomplished things or have reflections back on what they've accomplished or not. But it's probably as equally powerful to bring people on to like stages and get to have that real vulnerable, hey, this is what I'm wondering. Like, do you too feel like this? And maybe not there, maybe there's no answer, but just that knowing of like, oh gosh, this is something that I too have had to deal with, I think goes a long way in terms of empowering people to lean in.
I appreciate that. Just getting my thoughts together. What do you think some of the biggest challenges are for women in leadership? Have you been seeing, based on your own experience and then the women you're mentoring, a common theme or thread across them?
Well, I think that if you look across payment, like women in C-suite titles still get paid less than men in C-suite titles. So there's definitely a payment equity component. Yeah. And so that to me is a perception of how are women perceived to be valuable. And I think the ownership on women to push harder to negotiate and demand higher salaries. I think it's a combination, and one is easier to control than the other, but they both need to work in parallel. So I see that as a gap still. I also think that women, until you hit a certain level, have a harder time of being authentic. And by that, I mean, it's like, it's okay to be a mom and have kids and do those things, but it's not always okay to talk about it. Right. And you get to be this person who's like, I lead all the time with like, my car's got Cheerios in the back. Like, I'm a soccer mom. Like, I got kids behind me. There's guinea pigs often on the podcast when I'm with them. Like, they're sitting behind my shoulders. And I do that not only to make people laugh, but to, like, with intent. Like, that is actually how I live. And there are other people, men and women, and it's okay. That's how you live. At the end of the day, you're held accountable for what you do. Yeah. Right? And so to be able to be okay with being whatever that is and allowing women to think that's okay, even if it's different. Right.
Yeah, being different. I remember feeling a little self-conscious because we're a distributed team, remote, and we've been remote for a long time, since the inception of the business 20 years ago. And we would do Zoom calls, and here I am in my home office, which is also my bedroom.
Right, exactly.
And then the world came home. And it just changed everything because everyone's kids were walking in and out of the room. And I feel like that has been a blessing, that the humanity, I think, of our real lives are starting to show. Oh, Calvin, I'm noticing there's some background noise in my space. Do you hear that? Calvin, Marty. Okay. Some clanging and banging. Oh, yes.
Those came from mine. I tried to silence them.
Do you have the focus? You do that little thing at the very top of your menu bar? Okay.
Yeah, I know. It's still annoying. I shut down everything, but I heard it come through as well.
It's all right. Calvin's a magician. Okay, yeah, I know that they're taking down scaffolding next door. So it was just funny to like literally see people struggling with their own lives in the backdrop of Zoom calls.
Sure, really.
Are there other things, I'm just going to ask you, Jenny, that you want to share about? We can go back into more what's going on with Homeward and some groundbreaking things going on there. We can talk about some of your athletic pursuits and just give us a little more of who you are. Do you have a preference for which way we go?
Oh, both sound fine. Either one, you pick.
Okay, cool. Yeah, Calvin? Yeah, please. You're listening. Yeah. Well, why don't we start at the beginning? Like, you are a physician.
Yep.
You are MD.
Yep.
So describe for us, like, where did this idea, recognizing the problem with access to care in rural areas and making the biggest impact?
Sure. I grew up in Winona, Minnesota. I grew up with a very large family. My dad's the second oldest of 10. My mom's the oldest of 5. Everybody grows up and lives in Winona. I have 63 cousins on my dad's side alone. I am the third oldest grandchild, and my grandmother passed away during COVID just a few years ago. Not from COVID. It was time for her to go. She had a beautiful, wonderful life and a very celebrated and loved passing. Are
you the firstborn in your family?
I'm the middle.
Well? You're the middle. Okay.
I have an older brother and a younger brother. And I think of that as an advantage, having an older brother. I think firstborn children often get a lot of the parental pressure, and middle children can watch where they get into trouble and find other workaround methods to do the same thing and not get in trouble. So it's like you have a learning example in front of you. And I got interested in healthcare when I was 12, and I was diagnosed with type 1 diabetes. And that was my entree into healthcare. And I had an incredibly fortunate interaction with my own endocrinologist, Dr. Nelson, at the Mayo Clinic. And when I say fortunate, it's because I was 12 and he let this be my thing. He truly gave me the tools, the assets. I had very frank conversations around what was drinking going to do to my blood glucose? Like, when I had sex, what would that be like? And so these ideas of like being a real person and understanding this condition setting. So I was a middle child. I'm competitive by nature, felt like something really hard to do that no one had done. So applied to medical school, ended up going to Johns Hopkins for medical school. Thought I was going to be an endocrinologist because this was my idol and my doctor. And then I sat through medical school, and I hated every minute of endocrinology because all I could think of was how they talked about the people with diabetes. They called them diabetics. They said they were non-adherent, they were non-compliant. And I sat there thinking, man, this stuff is really flipping hard. And this whole group of very smart people are judging the patient and the words that they use, that it's their fault, like that they didn't actually do the right thing. If you had to count every time you opened your mouth and put a carbohydrate in and try to measure that and manage that with insulin and exercise, it's a really complex condition.
Yeah.
So I decided no on endocrinology. I decided yes in internal medicine because it was complex, because I trained at Hopkins and there was a line that all smart people go into internal medicine. So I bought into that as well. And then in the training, I loved the training. I loved the team aspect. I loved the intellectual rigor. I loved the hard work of the training, medical school and residency. And then I got out in the real world, and it felt like I was doing the same thing all the time when I was seeing patients. And and it felt interesting, but that almost anybody could do it. And I take that with a little grain of salt, but you had to be, any monkey could be trained to do what I was doing. You had to be a smart monkey, but any smart monkey could be trained. And I want to do something bigger. And so I got back into looking at databases. I went back to graduate school and got a master's in health services research and said, can I do something at a population level that could actually really bend the curve of healthcare? And at that time, I was looking around the industry and the ecosystem, and there's the likes of EVP and Chief Medical Officer Troy Brennan at CVS, who gets cigarettes banned. Like, he got cigarettes banned. And like, that's incredible to me. And I'm like, whoa, like that's going to have more impact than me treating this person to bring their blood pressure down by a little bit. And so I got really excited and had the opportunity to come across. I worked under a gentleman named Alan Garber. He's a health economist. He's now a provost at Harvard. And he has this crazy friend, Giovanni Colella, who was a serial entrepreneur who was starting a new company, trying to make a free market in healthcare. And I was like, that's great. I was thinking, I'm hundreds of thousands of dollars in debt from medical school. And my friends complain about dropping $20 at the doctor, but they'll easily pay $200 to the girl that never graduated from high school for a haircut. I'm like, how is this? Like, how is this equitable? Like, we're not even valuing things on. So I got really drawn into that journey and that ride, learned how to build products, learned how to impact things in a different scale. So the idea of starting companies. I watched Giovanni assemble incredibly talented, smart people, bring them together in a mission. And I was the speed, the evolution, I was hooked. I met someone interviewed for the position I took at Livongo, my person I shared an office with when I was at Stanford doing my master's. Daniela Pearl-Roth is her name. She's one of the smartest women I've ever met. And she said, hey, Schneider, I think this is a job for you. And so I interviewed for the same job. And I was like, yeah, this is great. At that time, Livongo was interviewing for chief medical officer. And I thought what they were trying to do was leverage data for people living with chronic conditions to change behavior. So I fell in love with that and joined the company, transitioned in the role of president, oversaw a bunch of the company, helped build, grow, take it public, sell it. And like where I landed at the end of the day was where this conversation started, which is I wanted to do something big, hard, at scale that could really change healthcare. And again, our approach in rural healthcare markets is taking a population that they're predominantly white and immigrant, disproportionately Medicare and Medicaid, and have very low access to a high quality healthcare. It's inequitable. We're solving an equity question. We were looking at equity not from a gender or from a race, but from a geographic lens. How can we make healthcare delivery more equitable? Just in the time where, and if you look around the ecosystem, and Livongo led some of this, but there's so many more great companies in the mix where technology, artificial intelligence was really prevalent and established a path forward to do things differently. And you cannot bring higher access, high quality healthcare services to hard to reach places without technology. And so we thought the timing was right for the delivery of the services in an economic model that the world, I think, is generally moving toward, which is let's get paid for the outcomes. Everybody can get paid appropriately. There's enough money to make sure everybody's getting compensated for the work that they do, but let's allow them to do the work that we need them to do at societal level versus an individual payroll model. And so that was the evolution into Homeward. I think I rambled a little bit on that one.
No, I love it. Just as you recognize the need to have providers as part of the mix for Livongo to succeed and achieve your goals, the vision that you had, have you recognized at this moment some missing pieces to the puzzle, or that your dream, that it's part of the plan down the road? What other elements of the ecosystem are required to help you achieve what you're looking to achieve with Homeward?
I think what we know is that it's an alignment and a non-competition, meaning you have to leverage the ecosystem, the pieces and parts that are there in the rural market. We talked a little bit about that. It's really critical. So understanding the great relationships you can have with pharmacists and the role that pharmacists play, community health workers, who are the influencers within a community, who are the social services that are available and adequate, and ensuring that people are getting to what they need and what they deserve and helping navigate that is a really critical part. This idea around creating something brand new to bring in and solve a problem is not the right approach. I liken it to, I've remodeled a house and I've built a house before. This is not a building of a house. This is a remodeling. And it's hard. It's hard. People's brains are wired differently. I actually do better in a remodel than I do in a build. But in a remodel, it's like you get to turn around and evaluate and see all the valuable things that exist. You just maybe need to change the route to get from one room to the other room so that you can optimize it. And so there's a lot of value in approaching rural healthcare markets in that fashion.
The noise. Oh, okay. Wrap it up.
Sure.
Jenny, we're going to have you back.
Thank you so much for the chance to connect. And I really loved getting to be in conversation with you. So thank you.
Jenny, this has been such a great conversation. We're thrilled to meet you and hear about the work you're doing. I'm just inspired by your drive and your desire to give back and the contribution you've made really to impact healthcare at a large scale across the country and help people get the care they need and improve their well-being.
Oh, thank you. Well, I'm one of many, and I've had many people invest in me along the way. And so delighted to get to help in any aspect I can.
Thanks for joining us for the Game-Changing Women of Healthcare, a production of the Krinsky Company. Today's episode was produced by Calvin Marty, Chelsea Ho, Medina Shabich, Wendy Nielsen, and me, Meg Escobosa. This podcast is engineered, edited, mixed, and scored by Calvin Marty. If you enjoy the show, please consider leaving a rating and review wherever you get your podcasts. It really does make a difference. And share the show with your friends and colleagues. If you have any questions, comments, or guest suggestions, please email us at podcast@thekrinskyco.com and visit us on the web at thekrinskyco.com. Interested in supporting this show and reaching our engaged audience? We're looking for sponsors for this season. Help us put the spotlight on women leaders in healthcare. Email us at podcast@thekrinskyco.com. And thank you.